Am I audible, guys? Yes or no? Fine. Hope I'm audible. Then we can start the class. Fine. So, these are the topics we are going to cover today. We will be covering today communicable disease. Some non-communicable disease questions we will cover. Okay, fine. Good evening, guys. Okay. Now, so I have some 13, 14 questions are there. Then we have some MCQs are there. Now, discuss the causes and mode of spread of dengue and add a note on primary and secondary prevention of dengue fever. Okay, this is an essay question. It's the essay question. Okay, causes and mode of spread. Okay, so let's start with agent. Just quick outline. Just quick outline. Okay, what is the agent? Agent is a type of flavivirus. It has 4 serotypes are there. Okay, dengue 1, 2, 3 and 4. 4 serotypes are there. Host factors. A means age and guys. Severe in infants. Okay, chronic diseases is there, means it will be severe. Obesity means it will be severe, guys. This is severe. These are age and host and environment. What about environment? If you see here, dengue is usually seen, okay, in urban areas. More common, okay, more common in urban areas. Okay, because of unplanned urbanization, breeding sites will be very common. What about the vector here, guys? What about the vector? Vector is Aedes aegypti, Aedes albopictus. Can you tell me where this mosquito will breed, guys? Aedes mosquito. Can you tell me where it will breed? Okay, yes, you can tell me where it breeds, guys. Aedes aegypti and Aedes albopictus. Where it breeds? They breed in artificial containers. Okay, keep answering so that it will be interesting for you also. Okay, so the vector is Aedes aegypti and Aedes albopictus. Okay, fine. So you will have an incubation period of 3 to 10 days. The patient can present as dengue fever. Okay, you may not see malaria also. Fine, good. Okay, but you will be seeing lot of what cases? Dengue cases. Okay, fine. Nowadays dengue is very common. Okay, what are the types it can present? It can present as undifferentiated fever. Undifferentiated fever. It can present as undifferentiated fever. Like any other viral fever, it can come and it can go. Second, classical dengue fever. Can you tell me what are the classical dengue fever symptoms will be? Can you tell me what are the classical dengue fever symptoms will be? The classical dengue fever symptoms will be patient will be having fever, joint pains will be there, joint pain, back pain, yes. Chills you may not find here, chills you will find in malaria more. Joint pain, back pain, rash will be there, and retroorbital pain will be retroorbital. These are features of classical dengue fever, and both these conditions will be self-limiting. But we are worried about dengue because of dengue hemorrhagic fever. We are worried about dengue for dengue hemorrhagic fever. What are the symptoms? Okay, additionally you will have. Why dengue hemorrhagic fever happens? Dengue hemorrhagic fever happens because of reinfection with another serotype, guys. Reinfection with another serotype. What do you mean by that? So that means if a patient is with dengue 1 serotype, patient is already infected with dengue 1 serotype, One more mosquito is coming and biting him with dengue 2 serotype. Okay, one more mosquito with dengue 2 serotype. This reinfection can cause this. So what are the features of dengue hemorrhagic fever, guys? Yes, you can answer it. Come on, what are the features of dengue hemorrhagic fever? Patient will have what? What are the dengue hemorrhagic fever? Thrombocytopenia. Okay, thrombocytopenia. Platelet levels will be less than 1 lakh. Raising hematocrit will be there. Raising hematocrit. Okay, and the patient will be having positive tourniquet test. Okay, tourniquet test. Okay, you do the BP cuff. Use the BP cuff, and you have to inflate it for 5 minutes. After 5 minutes, you just keep it there. Okay, inflated BP cuff, and after 5 minutes, you look for petty K. The petty K more than 10 per square inch means it is positive. The number of PTK is more than 10 per square inch means it is positive. This is dengue hemorrhagic fever. Patient is already reinfected with another serotype. Okay, fine. The fourth one is dengue shock syndrome. Okay, dengue shock syndrome. So patient will have DHF features plus shock features will be shock features. Okay. Bleeding from any natural orifices. Okay, yes, fine. That is bleeding manifestations will be there. But that is a very late phenomena, Deepika. That's a very late phenomena. Okay, you can identify early. Now, how will you confirm it's a case of dengue? We have various investigations are there. Various investigations. Okay, you can do early fever means NS1 antigen you can do. You can do look for IgM antibodies you will look. 6 or more than 6 days fever. And best one is RT-PCR. RT-PCR. This is the best investigation is RT-PCR. What is the treatment here? What is the treatment? There is no specific treatment. No specific treatment. Okay, what you will have fluids. Okay, fluids, plenty of fluids, no NSAIDs. Okay, avoid NSAIDs, plenty of fluids. Okay, you may say that platelet transfusion, but there is a very late mechanism. Platelet transfusion you require when platelet levels are less than 10,000. Okay, at this time only you require this platelet transfusion. Platelet transfusion. Now, there is no specific treatment, guys. There is no specific treatment. Okay, fine. Now, how to prevent it? Okay, how to prevent it? Okay, what we can do to prevent it? What we can do to prevention? Prevention, how we can do? That was the question. Primary and secondary level. Primary level, the first one what we can do is integrated vector control. Okay. This can come as a separate short note for you. Integrated vector control. What comes in integrated vector control? Okay, what comes in integrated vector control? You may go for anti-larval measures. Okay, anti-larval measures such as, okay, any question on this you can write this case. Any question on this you can write this. Okay, fine. So in environmental control, there is no water stagnation. There is no water stagnation. Or you can use chemical control. Okay, you can pour oil, mineral oil, Paris green over it. Okay, so what can happen? So it forms a layer over the water, so the larva will die. You can use biological control, for example, Gambusia fish. Okay, biological control. Okay, so this is okay anti-larval mission. This larva they will eat, guys. This Gambusia fish they will eat. This is anti-larva. Second is anti-adult. You can do anti-adult. You can do anti-adult, guys. What you can do? Okay, anti-adult you can do is okay spray. You can do indoor residual spray. Indoor spray you can do, or you can do space spray. Space spray you can do. Okay, third is personal protection. You can do personal protection. Okay, personal protection. This we call it as, if you use all these methods together, okay, all these methods together, this we call it as integrated vector control. So not only one method, use all these methods together, this we call it as integrated vector control. Of this is primary prevention you can do. One more primary prevention you can do is vaccination, guys. We have a vaccine available called as CYD-TDV. It's a live vaccine. Live vaccine available, you can use it for dengue. Okay, fine. For secondary prevention, what you can do? For secondary prevention, what you can do? Okay, identify case early. Identify cases early. Then you can isolate them. Isolate them and treatment. This is secondary prevention. Okay, you can identify the cases early and you can isolate them and treatment. So are we clear? So this is about dengue, guys. This is about dengue. Okay, so primary prevention, vaccination and integrated vector control. No mosquito means no dengue. Secondary prevention, identify the case early and treat them. Fine. We'll go to the next question. Describe in detail classification of exposure, post-exposure prophylaxis on wound management of a dog bite case. Post-exposure prophylaxis classification. Fine. So how are you going to categorize? Suppose a patient comes with a dog bite. So what you are going to do? The first step is, okay, we will do wound washing. So local management, wound washing with soap in running water, guys, not just any water, running water for 15 minutes. Okay, 15 minutes, not just tap, not just pouring from the bucket and all. Okay, you should use running water, tap water, running tap water for 15 minutes. Okay, use povidone or any form of, okay, tincture or anything. Okay, just remove the virus, okay, from the site of bite. Okay, use antivirus agent. Avoid suturing, guys. Avoid suturing for 24 to 48 hours. Don't do suturing, because if you do take a bite, okay, there may be chance that what can happen is you will create a nerve endings, the virus can assert. Okay, fine. Fourth step is you can provide TD vaccine, and need is there means antibiotics you can give, antibiotics. So you can give amoxiclav, okay, like that antibiotic we can provide. And fifth is that, so you have to provide either vaccine or immunoglobulin. Okay, if there is too much bleeding, okay, so you have to make compression, guys, make it compression. There should not be any bleed, this one suturing. Okay, fine. No, don't do suturing. Okay, compress it, as much as compression bandage you can try. Fine. Vaccine or immunoglobulin. Vaccine or immunoglobulin. So to give vaccine or immunoglobulin, we have to make categorization. Category 1. Category 1 is touching or feeding. Touching or feeding licks on intact skin. Okay, any animal is there, dog is there, cat is there, touching or feeding, licks on intact skin. Okay, what is required means nothing is required, guys. Nothing is required. For category 2, okay, if nibbling is there, nibbling and abrasions, abrasion without bleeding, guys, without bleeding, no bleeding, bleeding is not there, no bleeding, but nibbling is there, okay, abrasions are there, okay, they will come to you and without bleeding. Okay, so what you are supposed to do here? Okay, what you are supposed to do here? So here you have to provide ARV, guys. ARV. If animal is healthy means, okay, after 10 days. After 10 days. Okay, after 10 days means stop. Good, good. Okay, fine. You're answering nicely. Now, ARV, if animal is healthy after 10 days means stop it. This is category 2. If category 3 means any abrasions with bleeding, guys. Abrasions with bleeding. Okay, abrasion is there, with bleeding is there. Okay, laceration is there. Okay, head and neck bites. Okay, even if it's just very small bite, head and neck bites is there. Okay, wild animal bites is there. Wild animal. So if these things are there, multiple bites are there. Okay, what you are supposed to do? You have to provide ARV plus immunoglobulin. You have to provide. Okay, IG means immunoglobulin. ARV plus immunoglobulin. So immunoglobulin you should infiltrate. Okay, around the site itself you should infiltrate. You have two types of immunoglobulin you have. Okay, that is what? Human immunoglobulin, equine immunoglobulin. Okay, fine. Again, same principle, guys. If animal is healthy after 10 days, you can stop it. That means the animal is not having rabies. Okay, we are rule outing rabies in the dogs or the animal, whatever. So, what is the post-exposure prophylaxis? We'll be seeing cases, guys. Okay, once you become intern, okay, you can see in the casualty. Okay, you can see the cases regularly. So, post-exposure prophylaxis, you are going to use vaccine is human diploid cell culture vaccine. Okay, we are going to use human diploid cell culture vaccine. Okay, we have two regimens are there. Okay, one is that essence regimen. Okay, essence regimen. Essence regimen, when you are going to provide this essence regimen, this is intramuscular regimen, guys. 0.5 ml IM you are going to provide. Okay, 0, 3, 7, 14 and 28 days. So you are going to provide 5 doses, guys. 5 doses, 2.5 ml you are going to provide. This is essence regimen. Essence regimen. The next one is, okay, updated or modified Thai regimen is there. A Thai regimen. This is given intradermally, guys. This is given intradermally, 0.1 ml, 0, 3, 7 and 28 days. But every time whenever you are giving, you have to give it at two sides. Two sides you have to provide. Okay, right arm means left arm also. Two sides. Okay, here also you provide, here also you provide. Okay, fine. So you see here, okay, okay, 4 days you are going to provide. Okay, 8 doses you will provide. 8 doses. Okay, so 8 doses you will provide. Okay, 8 doses and totally it is 0.4 days, 0.8 ml. Okay, 4 days, two sides, here also, here also. Intradermally you are going to provide this. Okay, so most of the government hospitals, they will provide this because the dosage is lower. That is the advantage. Okay, I have updated Thai regimen. What is the advantage? The dose is low. It's only 0.8 ml. Okay, compared to essence regimen, it's 2.5 ml. It's costly. It's costly. In a government setup, we can do because lot of cases will come. Lot of cases will come. But if you are seeing a occasionally rarely case comes, means you have to go for essence regimen because the vial comes in 0.5 ml. Okay, fine. This is pre-exposure, and you will provide immunoglobulin. Okay, immunoglobulins. Human you have, equine you have. Humans is 20 international units per kg. Equine is 40 international units per kg. Okay, essence regimen is 0.5 ml. Okay, it's 0.5 ml Aditya, but the total dose, okay, this is 0.5 ml. 0.5 ml. Essence regimen is 0.5 ml, but the total dose is 2.5 ml totally for 5 days. The regimen value numbers is higher. So hope this is clear. We'll go to the next question. Go to the next question. A mother of 8 months old child coming to PHC with the complaint of breathlessness for 1 day. The baby having fever for past 4 days. Okay. So breathlessness, fever. On examination, a respiratory rate of 64 without chest in drawing. They are asking us classify the patient as per IMNCA guidelines, okay, and discuss the treatment and how can you prevent it. Okay, so we have to see here IMNCA guidelines. A child with the respiratory symptoms, we have to follow these IMNCA guidelines. So what is the first step? First step is assess. Okay, so what are the things you are going to assess? So you will look for respiratory rate, guys. For 1 full minute we have to check. For 1 full minute count it. Second, look for chest indrawing. Okay, second, look for chest indrawing. So you have to see the lower chest during inspiration. During inspiration, okay, there will be indrawing will be there. So that is chest indrawing. That tells us whether the child is having pneumonia or not. Okay, fine. Third is that you should look for danger sign. A danger sign. Okay, danger sign means here stridor, easing, okay, vomiting. Easing may not come, stridor, okay, vomiting, convulsions, okay, not able to feed, okay, abnormally sleepy, okay, abnormally sleepy. Okay, fine. These things are there. Okay, we should think of a danger sign. Danger sign. Okay, fine. So based on the respiratory rate, okay, a child between 0 to 2 months, we are going to call it as, if it is more than 60 means you are going to call it as fast breathing. Okay, fast breathing. A child is having 0 to 2 months more than 60. 2 to 12 months it is more than 50. 1 to 5 years it is more than 40, guys. Call it as, okay, so fast breathing. Okay, fine. Now based on this, what does the child have? Child is no chest in drawing, but respiratory rate is how much? 64, guys. Okay, fine. That is more than 50, guys. That is more than 50. Okay, so how we are going to classify them? Now we have assessed this. Second step is classification. Classify. No fast breathing. Okay, there is no fast breathing. No chest in drawing. No danger sign. Okay, no danger sign. What is this? No pneumonia. You can make a diagnosis based on what we have discussed. You can make a diagnosis for the case. This is first. Okay, fine. Okay, this is for the age group. What we are seeing here is 2 months to 5 years. This is the age group. Second, fast breathing present or chest in drawing present, no danger sign. No danger sign. Then what is this? Pneumonia, guys. This is pneumonia. Fine. The third one is danger sign is present means is severe or very severe pneumonia. Here are very severe pneumonia. Danger sign is there, severe or very severe pneumonia. Okay, right? This is a classification. Okay, fine. Now, what does the child have? The child here has only fast breathing. So the child is having only fast breathing means what it will come? Will come this pneumonia, guys. Pneumonia. Color coding we have to follow. It's pneumonia. Okay, what's your diagnosis? Means it's pneumonia. How will you treat a case of pneumonia here? So we have to provide antibiotics. So we have to provide amoxicillin. Antibiotics we should provide is amoxicillin. So fever is there, so you have to provide paracetamol. Cough is there. Okay, treatment for cough. Okay, treatment for cough. So those things we have to provide. Okay, but we have to provide antibiotics. Okay, antibiotic. This is amoxicillin. We have to provide the amoxicillin. Now, how will you prevent it? Diagnosis we have made, treatment we have said. So how will you prevent it? Prevention can be done. That is why, okay, prevention of ARI, acute respiratory infection. One is you have to vaccination. Most important thing is vaccination. What are the vaccines? Measles can cause. Measles complication is pneumonia. Okay, so most common cause of death, most dangerous complication measles is pneumonia, guys. Okay, you should vaccinate measles at 9 months. Okay, again at 16 to 24 months. Fine. Second is we have this H influenza B. Okay, it is part of pentavalent vaccine. Okay, we are providing pentavalent vaccine at 6, 10, 14 weeks. Okay, fine. Pentavalent vaccine we are providing actually. Measles 9 months, 16, 24 months. Third is that we have another vaccine is available, pneumococcal vaccine. Pneumococcal vaccine. One is we have polysaccharide vaccine is available. Another one is what we have is okay, conjugate vaccine. Conjugate vaccine actually we are giving in the program, guys. A conjugate vaccine, it is given in the program at 6 weeks, 14 weeks, again at 9 months we are giving. So these are the vaccination we provide. This is how we can do prevention. Prevention of ARI, basically vaccination. You can avoid indoor air pollution, okay, and also in terms of smoking, okay. Second-hand smoke if the child is avoiding, so we can prevent it. So we have completed this ARI, guys. ARI. Go to the next question. Describe National TB Elimination Program. The headings of target, strategic plan, diagnosis, and management of TB patient. They are asking for in terms of diagnosis as well as management. Okay, management. Fine. This is the logo for TB, NTEP. This is the logo for NTEP. So the goal is to eliminate TB by 2025, guys. Okay, so we want to eliminate TB by 2020 and we want to have a TB free India, guys. We want to have a TB free India with 80% reduction in TB incidence, 90% reduction in mortality, and 0% of patient having catastrophic expenditure due to TB. So nobody should spend from out of their pocket. Nobody should have a catastrophic expenditure because program itself is providing most of things free. Now what is this strategies? Okay, what is the strategy? Detect the case, treat it, prevent it, guys. Okay, and build. Fourth step is build. Okay, detect the case, okay, and treatment initiate and sustain all patients. Detect the case and treat it. Okay, so prevent the emergence of TB in susceptible population, and whenever feasibility is there, build enabling policies. Right. Now what is a TB case? Any patient you are seeing fever more than 2 weeks, cough more than 2 weeks, hemoptysis. If a patient is having hemoptysis, fever, cough, weight loss is there, weight loss, or any abnormality in chest X-ray, rule out TB. You are supposed to rule out TB. Okay? Fever, cough, hemoptysis, weight loss, and you are taking X-ray for some other reason, but the patient is looking like a features of TB. Then what you are supposed to do? You are supposed to take sputum. You are going to take. What is the investigation? Sputum plus chest X-ray. Any one is there, you rule out this. Any one is there, rule out. There is a cough also having fever also. Any one is there. Okay, so sputum, chest X-ray. Sputum if you take, okay, so how many sputums? Two sputum, guys. Okay, two sputum you have to take. One is, okay, two sputums. One is on spot, and another one is early morning. What is the advantage of early morning sputum, guys? It is asked in Viva. Okay, two sputum. One is early morning sputum. Why? Why? Can anyone tell me why? Okay, two sputum you are going to collect. Two sputum, and another is chest X-ray, guys. And chest X-ray. Now, both sputum are positive, or even one sputum is positive. It's a case of TB. Case of TB. Even if one sputum is positive, it's a case of TB. Both sputum are negative. Both sputum are negative. X-ray looks positive. This is the algorithm. This is the algorithm. Okay, so both sputum are negative, but X-ray looks positive. Okay, then we have to go for a confirmatory test called as CB nut. What is CB nut, guys? Can anyone tell me what is CB nut? CB nut means, yes, you can tell me. If CB nut is positive, it's a case of TB, guys. CB nut negative means no TB. Okay, CB nut negative means it's no TB. This is the algorithm. Okay, both sputum are positive. Okay, TB. If both sputum are negative but X-ray looks positive, go for CB nut. CB nut means cartridge based nucleic acid amplification testing. So based on this, you are going to start the treatment. What is the regimen available? We have category 1 is there. Okay, we have this intensive phase. What is the regimen, guys? You can answer this, guys. Intensive phase and continuation phase. What is the regimen that is given for TB? Yes, you will also get a case also. Come on. So category 1, what is the regimen? 2 HRZD, 4 HRE. This is the regimen, guys. 2 HRZD and 4 HRE. Okay. Isoniazid, H means isoniazid, R means rifampicin, pyrazinamide, ethambutyl. So 2 months of HRZD and 4 months of this one, guys. Okay, 4 months you are going to provide. Okay, for totally 6 months. And treatment is daily, guys. Treatment is daily. And what we are providing in this treatment, guys? Okay, so we are having this. We are also providing this nutritional allowance. What is that called as? Nikshay Poshan Yojana. Okay, we are providing, as of the latest guidelines, 1,000 per month during treatment, guys. Nikshay Poshan Yojana. We are providing nutrition allowance to the patient. Okay, in terms of nutrition, transport, they can use it, guys. Okay, fine. And how the drug monitoring is done? Treatment monitoring is done by. Can you tell me what is this image, guys? What is this image? What is anyone? Anyone, can you tell me? This is what treatment monitoring is. This is for treatment monitoring we are using it. What is this one? Okay, what treatment monitoring? What is this called as? 99 dots. Okay, so patient every day when they take the drug, this is the drug strip given to the patient. Every day when they take the drug, in the back side of the drug strip, there will be a toll-free number will be there, and you are going to call from your registered mobile number to this toll-free number. That means you have taken the drugs. Okay, the toll-free number will vary. On this back side, it will be there. This is called as 99 dots for treatment monitoring. For treatment monitoring. Okay, fine. So hope this is clear. Shall I continue, guys? Are you guys able to follow this? Yes or no? Fine. Write in detail the epidemiology of polio, guys. Question again. This is essay question. So far, we have seen all our essay questions. All our essay questions. Discuss the strategies for eradicating poliomyelitis. Okay, fine. I'm just giving the creamy point. So look here, polio, if you see, agent is poliovirus, guys. What is the agent? Poliovirus. How many serotypes are there? So we have this first one, it is associated with wild virus. Type 2 is causes this VDPVs. Can cause a condition called as vaccine derived poliovirus. Type 3 causes. The main reservoir for this condition, it is humans. It does not occur in animals. It does not occur in animals. Okay. Which age group it is common? This is epidemiology. 6 months to 3 years. Post factors, it's common in the age group of 6 months to 3 years and more common in male children. Male children. Can you tell me how this polio is transmitted? What is the mode of transmission of polio? Okay. So, which area it is common means poor sanitation. Poor sanitation. Polio is common in those areas, poor sanitation. So, low underdeveloping countries, okay. So, underdeveloping countries, okay, like African countries, okay. Previously used to be common in India. And mode of transmission is fecal-oral route, okay, fecal-oral route. Fecal-oral route. And the incubation period for this condition is 7 to 14 days. 7 to 14, that is the incubation period for this condition. So this is the epidemiological features. Clinically, how it can present. Clinically, if you see, 95% of cases are inapparent infection. They won't feel anything. Inapparent infection, polio. Okay, the tip of iceberg. Okay, the hidden portion. Yes, iceberg phenomena will be a lot. Okay, fine. Okay, most of the cases they are inapparent. Less than 1% can go for paralytic polio. Paralytic polio. Okay, fine. What type of paralysis you will find? Okay, descending asymmetric flaccid paralysis. Okay, the type of paralysis you will see is descending asymmetric flaccid paralysis. In 90s, India is having the highest case of polio. Since 2011, we don't have case of polio. How we achieve this? We achieve this basically by two reasons. One is pulse polio immunization. Pulse polio immunization. We will be celebrating National Immunization Days. 2 days in a year, guys. 2 days in a year. The month of January, February, March, like that. We will be celebrating National Immunization Days. On these days, we will be immunizing all children less than 5 years. Less than 5 years to be vaccinated. All children. This is pulse polio immunization. Second, for every case, we will be doing this AFP surveillance. AFP surveillance. Any child less than 15 years with acute flaccid paralysis. Okay, any child less than 15 years with acute flaccid paralysis, you have to rule out polio, guys. Okay, polio. So you have to collect stool specimens, you have to collect, and you have to check the residual paralysis. At 60 days, you have to check this. Any child less than 15 years. Any child less than 15 years, you have to rule out polio. Stools, you have to check, and residual paralysis, you should check at 60 days. Now, what are the things? Okay, what are the strategies here for polio eradication in India? The first is conduct pulse polio immunization every year, guys. What is that? So we have to celebrate, okay, National Immunization Day, right from Kashmir to Kanyakumari, all children less than 5 years to be vaccinated. High levels of routine immunization we have to maintain. So what is the age group we will provide? We provide at birth, we provide OPV. 6 weeks, 10 weeks, 14 weeks we are providing OPV guys. Okay, fine. Monitor the OPV coverage. If any case is reported polio, so go for rapid investigation, and follow-up of AFP cases at 60 days should be done to look for residual paralysis. Whether the child is still having paralysis or not, you are going to check. Conduct outbreak control. If cases is confirmed, okay, in that area, go for a conduct outbreak control, like by giving OPV to all the children around the case. Okay, fine. These are the strategies, guys. These are the strategies for polio eradication in India. Next question. Yes. A 38-year-old male child on routine screening was found to have fasting blood sugar of 146. A postprandial blood sugar of 210. Okay, blood pressure of 136 to 86. What is your diagnosis? Enumerate the risk factors for this condition and discuss the preventive measure. What is your diagnosis, guys? Can you tell me what is the diagnosis? So we are having a fasting blood sugar more than 146, a postprandial more than 200. It's a case of diabetes. Okay, but blood pressure is 132. We cannot say that a hypertensive. Okay, so we can say this is a case of diabetes. So what is the criteria to call it as diabetic? Cutoff value according to Park textbook. Okay, we'll keep it that where they have given the WHO recommendations. So fasting blood sugar, this is venous blood more than 126. Overnight fasting. 2-hour post-load venous is more than 200 milligram. So both it fulfills. If you are seeing HbA1c, if it is more than 6.5%, so we can think of this for diabetes. Now, what are the risk factors to get for diabetes? So we have age and factors are there. So basically, so type 2 only we will be focusing, type 2. Okay, so either insulin deficiency or resistance. Insulin deficiency or resistance. It may be due to pancreatic disorders or defects in the formation of insulin or due to destruction of beta cells, decreased insulin sensitivity. So these things can either there is a decrease in production or decreased in insulin sensitivity can cause this condition. What about host factors? Okay, usually if you see, okay, it increases with age, especially type 2. We are more focusing type 2. Okay, fine. Family history. Okay, family history. If you have family is affected, there is more chance that you will also get this disease. Parents are there means more risk. Obesity. Okay, so we have this high BMI. Okay, that can lead to diabetes. Okay, what are the other factors? We cannot say environmental factors. Sedentary lifestyle. Okay, so saturated fat. Saturated fat means here animal food. Okay, less dietary fiber. Okay, less dietary fiber. Saturated fat increases the risk. Okay, and stress can lead to this. Okay, these are some of the important factors that can contribute. Okay, so age and host and environmental factors. Nowadays diabetes are very common. You can have modifiable, non-modifiable, age, family history. You cannot modify it, guys. Sedentary lifestyle, diet, obesity, stress, these things we can able to modify. That is why it's called as modifiable risk factor. What you can do for prevention and control? So diabetes, if you see primary prevention, so that means what is primary prevention is before the disease. So whole population you can tell them to weight maintenance of normal, okay, healthy nutritional habit. These are population strategy. That means focusing on the whole population. Whole population you can tell them. Then what is high risk strategy? Okay, you identify high risk people. So those are having sedentary lifestyle, diabetogenic drugs are there. Okay, in those people, if you are focusing, okay, to control, okay, to make sure that they don't have diabetes. Okay, so avoidance of risk factors in high risk people. So these are high risk people. High risk people, if you are focusing these things to these high risk people, then it is high risk strategy. Now, what about secondary prevention, early diagnosis and treatment? Secondary prevention. So secondary prevention means you have to focus on diet. Diet means, okay, so low glycemic index foods. Okay, diet, along with you can use anti-diabetic drugs, insulin, and also exercise, some form of physical activity. WHO recommends, okay, you should take care of physical activity minimum 150 hours, 150 minutes per week, guys. Minimum 150 minutes per week. So diet, okay, so diet and anti-diabetic drugs, okay, or insulin you can use, okay, and physical activity should be there, okay. Avoids, lower the stress levels. Stress, good sleep is required. All these things you can do if you diagnose a case of diabetes. Okay, fine. So routine checking should be done. Blood pressure. This comes in foot care, guys. This comes in foot care. So routine checking should be done. Okay, BP, visual acuity, foot care. Okay, so that's taking care of themselves. Okay, you can use the diabetic card. They can have. Okay, diabetic card. Okay, so taking care, that is self care. Self care is comes as a short note for you guys. Separate self care. Okay, it's a chronic disease. It will be there for lifelong. Okay, the patient should know what I should eat. Okay, when to go for treatment, when to go for checkup. That is self care. Self care has to be there because there is no cure for it. So it's a chronic disease, lifelong disease. That's the problem with diabetics. These are the various activities done in our program. So we have this program called as National Program for Control on for this CDCS, cardiovascular disease, diabetes, okay, and we have this cancer is there, okay, and stroke. These are the 4 conditions. At various levels, we are taking some action. Okay, fine. So SHC means Health and Wellness Center. This okay, sub-center Health and Wellness Centers. So more than 30 years, we should start screening. We should start screening for more than 30 years. Okay, anybody is coming more than 30 years, we should start screening. Okay, so some form to look for, especially diabetes and hypertension. Okay, fine. So various levels we are doing health promotional activities, screening we do. Okay, diagnose and treatment. Okay, if the cases need referral, and you are going to refer it. Okay, fine. The name of the program is NPCDCS. Okay, fine. National Program for Control of, especially for this cardiovascular system, diabetes, cancer and stroke, guys. This is a short note, guys. So we have seen essays, we have seen. So next we will go into short notes. Okay, fine. MDT. What is MDT in leprosy? Multi-drug therapy. This is multi-drug therapy in leprosy. So basically, we are giving multiple drugs. Reason to prevent drug resistance. Okay, so interrupt transmission, early detection treatment, guys, so that we can prevent deformities. So how we are going to divide? So we are going to divide them into 2 categories. One is paucibacillary and multibacillary. First one is paucibacillary. Okay, fine, paucibacillary. Second is multibacillary. Okay, for treatment. 1 to 5 lesions or 1 nerve involvement, we are going to call it as paucibacillary. And more than 5 lesions, that is 6 or more than 6, along with more than 1 nerve involvement, we are going to call it as multibacillary. So these are the regimen, guys. These are the regimens that is available. Okay, fine. This is a blister pack. Okay, one is for children, one is for adults. Let us concentrate for adults, guys. This is what currently giving. Okay, government is currently what they are giving is this. So this is once a month rifampicin, guys. This one is rifampicin. Okay, rifampicin we are going to provide monthly, guys, monthly. This is for paucibacillary. Okay, fine. And the remaining drugs, these are dapsone. These are dapsone. These are dapsone. The white one is dapsone. Okay. So multibacillary, you are going to provide paucibacillary. Okay, once a month rifampicin, and daily dapsone you are going to provide. For how long? You are going to provide it for 6 months. A patient will be, they will be giving this drug. Okay, every month they will come and collect the drugs. This is for possible. What about multibacillary? Multibacillary, the first, this one is rifampicin. Rifampicin monthly, and you also have this clofazimine will be there. Clofazimine, and this is dapsone. So rifampicin you will provide monthly, guys, but dapsone and clofazimine you will be providing daily also. Okay, so clofazimine and dapsone you will provide daily. For how long you will provide? So you will provide it for 12 months. 12 months. So multibacillary you will provide it for 12 months, and paucibacillary you will provide it for 6 months. 6 months. Okay, fine. This is the treatment for okay, adult. Okay, we'll concentrate on adult, guys. Okay, so this may be changed. WHO they will change, but as of now for your undergraduate exam, this is more than enough. So what is this adequate treatment? Some other terminologies are here. So multibacillary, paucibacillary, if you are completing 6 months treatment in 9 months is considered as adequate treatment. And multibacillary 12 months, the patient is taking drugs on and off for 18 months, that is also considered as adequate treatment. Okay, adequate treatment. So this MDT regimen, the patient has not collected treatment for 12 consecutive months is considered as a defaulter. Not taken the treatment for 12 consecutive months. 12 consecutive months, we are going to call this person as a defaulter. This default. So we have completed this. What is this? Okay, MDT, guys. Management of multi-drug resistant TB. This is TB, guys. This is TB. So what is this MDR-TB? The investigation what you would like to do for MDR-TB is you would like to do sputum culture and drug sensitivity testing. Sputum culture and drug sensitivity testing. This is the investigation you would like to do. This is short note, guys. Again, a short note. Sputum culture and DST, drug sensitivity testing. Now, what is the investigation you have done? Now, what is MDR-TB? Okay, MDR means multi-drug resistance, means HR resistance. Okay, HR resistance. What is HR resistance means? Okay, resistance to isoniazid and rifampicin. Pre-XDR is there. Okay, pre-XDR means HR resistance plus fluoroquinolone resistance. Okay, so that is pre-XDR, but the question is MDR, guys. What is XDR-TB is also there. Okay, that means HR resistance, fluoroquinolone resistance, and the resistance to third one is bedaquiline or linezolid. Okay, that is XDR. The question is MDR-TB. MDR-TB means HR resistance, isoniazid and rifampicin. Okay, fine. Investigation is sputum culture and DST, guys. Now, what is the regimen? These are the various regimens available, guys. These are the various regimen. Shorter regimen includes, this comes in intensive phase and continuation phase. Shorter regimen, you have 4 to 6 months of moxifloxacin. This one has injection is there. Injection. Kanamycin and amikacin injection is there. Okay, fine. Ethionamide is there. Clofazimine is there. Pyrazinamide. Okay, and isoniazid. Okay, ethambutol. E stands for ethambutol. And continuation phase, you will not give injection, you will not give, and kanamycin, and you will not give this ethionamide, you will not give. Oral shorter regimen is there. We have this levofloxacin. Okay, instead of kanamycin, you are replacing with bedaquiline. And instead of moxifloxacin, you are replacing it levofloxacin. That is the difference here. Moxifloxacin you will replace with levoflox. Kanamycin and AM we are replacing with bedaquiline. all oral longer regimen you can. This is what is given in the textbook of Park, guys. Okay, fine. So 18 to 20 months you have to provide. This is 18 to 20 months. Okay, all 4 drugs, guys. Levofloxacin, linezolid, clofazimine and cycloserine. And bedaquiline you are going to provide it for 6 months. 6 months. Okay, bedaquiline alone 6 months. The remaining drugs you have to give for 18 to 20 months. All these treatments are very long duration. So recently, just for information, I'm just telling you. Okay, so government has recently launched for MDR TB, maybe asked in Viva also. So treatment is, their regimen is called as BPOM. BPOM regimen. Okay, this is given for 6 months. 6 months. What is the regimen? Bedaquiline, okay, pretomanid. Last 2 months. Okay, pretomanid. Okay, linezolid, moxifloxacin. This is called as BPOM regimen. Recently, by MDR-TB, this is launched by Government of India. BPOM regimen. BPOM regimen. Okay, so bedaquiline, pretomanid, linezolid, and moxifloxacin. It's for credit. Next question. Explain syndromic management for STD, guys. STD in India. What is this syndromic management? Look here. The syndromic management, the STDs are very common, guys. STDs are very common. Understand this. Sexually transmitted, very, very common. But the organisms will be, various organisms will be. Okay, so chlamydia will be there. Okay. So a lot of organisms, herpes will be there. Okay, so gonorrhea, chancro, various organisms. Okay, one of the traditional way, if you want to find what is the organism, then if you want to start treatment, it will be very difficult, because most of the time the investigation will be available at either district hospital level or medical college, and most of the time patient may not go there. That's why they started this, because by laboratory confirmation it's very expensive, not easily available. What government has, with the help of WHO, they said that they developed a scientifically, okay, approach they have developed, okay, derived approach. If a patient comes with a particular STD syndrome, you can directly start treatment with kits. Okay, you can directly start the treatment with kits. Okay, that is what this syndromic approach. We have various syndromes are there. Okay, so we have this colored kits is given. So we have this urethral discharge or anorectal discharge. The patient may come with vaginal discharge. Okay, in your book you will have flowcharts for everything. Okay, I'm just clubbing together. I'm just telling, if it's asked as a short note, you write this way. That is enough. Non-herpetic GUD, guys, genital ulcer disease. Non-herpetic GUD, where patient is penicillin allergic. This patient is penicillin allergic. A lower herpetic GUD, this is painful. GUD means genital ulcer disease. Lower abdominal pain is there. Looks like a STD. Inguinal buboes are the swelling in the inguinal region. If a patient comes with any of these STD syndromes, okay, don't go for investigations and all. Directly you can start the treatment. Okay, that is what this syndromic approach means. So if the patient is having this urethral or anorectal discharge, you can start with grey colored kit. Okay, so it will contain the drugs. These drugs it will contain. Vaginal discharge, a green colored kit. Colored kits are given. Non-herpetic GUD, white colored kit. Penicillin allergic means blue. Okay, a herpetic means red color. Lower abdominal pain means yellow. Inguinal bubo means it is black. Okay, recently also we have this brown colored kit. That, okay, we'll leave that. It's too updation. Okay, so at least you should be able to answer this. Okay, gray colored kit, green colored, okay, white color for non-herpetic GUD. If it is painful, red color. Lower abdominal pain means yellow. Inguinal buboes means it is black, guys. Okay, this is what these colored kits are. These are the colored kits. Okay, colored kits we have. Okay, yellow, okay, green, blue. These are the various colored kits we will provide. Okay, fine. What are the advantages? No lab investigation required. Okay, so it's very rapid. You can start it. All these STD clinics are renamed as Suraksha Clinic. Okay, all the STD clinic to avoid the stigma associated with that. So this is renamed as Suraksha Clinic. STD clinic has been renamed as Suraksha Clinic. Next question. Yeah, fine. So PPT-CT, prevention of PPT-CT, prevention of parent to child transmission. Okay, again, this is a short note for you. PPT-CT, prevention of parent to child transmission. Okay, so STDs are HIV. Okay, the mode of transmission from mother to child. Okay, mother to child, the risk is around 20 to 25% chance is there, okay, to get HIV. So what are the various levels, methods we do under the program? We are doing this 4 prongs. Okay, primary prevention. Okay, so primary prevention, we are creating awareness. We are creating awareness to all the, okay, we are starting from adolescent levels itself. We are starting it. Okay, adolescent, reproductive and sexual health, we are creating so much awareness. Okay, so that means, okay, to chance of reducing the chance of getting HIV itself. This is the first one. Second, if the mother is HIV positive, okay, second step is that you counsel her. Okay, so whether you need pregnancy. Okay, so to avoid the unintended pregnancies, so to prevent the unintended pregnancy, okay, before pregnancy itself you are doing counseling for HIV positive women. Third step is prevention of mother to child transmission. If HIV positive mother, if you comes, so what you are supposed to do? Okay, if the mother is HIV positive and pregnant, okay, so what they are doing, this program is that immediately start lifelong ART. ART means antiretroviral therapy. Immediately start irrespective of their, okay, CD4 count and clinical staging. This is what we do. Okay, so immediately start lifelong ART irrespective of the CD4 count and clinical staging. What is the drugs we are providing? So we are going to provide same drugs that is given in the adults case. Okay, what is the drug they are giving? Okay, TLD, tenofovir, so lamivudine plus dolutegravir. Dolutegravir. Immediately you have to provide for all HIV positive. Okay, so tenofovir, lamivudine and dolutegravir. Previously used to provide nevirapine. Now this has been increased to HIV positive. Is that you have to provide irrespective of CD4 count and clinical staging. We are giving the drugs, guys. Right. This is stage 3. What about this one? Care, support and treatment. Now the baby is delivered. For the baby, okay, we will be providing, okay, nevirapine syrup, guys. Nevirapine syrup for 6 weeks. Immediately we will provide this. Okay, for the baby. For the baby, we will be providing nevirapine syrup for 6 weeks. So care, support and breastfeeding will be continued, and nevirapine syrup is given, guys. So this is PPT-CT, guys, prevention of parent to child transmission. It starts right before in the adolescent period itself. The education for HIV starts. Then unintended pregnancy we are preventing. After that, what we are doing? HIV positive mother means, okay, positive pregnancy means we are going to provide the treatment, and if baby is delivered, baby is also given treatment. What is this oral rehydration therapy? The ORS, guys, okay, it is considered as one of the important discoveries. It is considered as one of the important discoveries in the last century because it prevented medical discovery. It prevented deaths of so many people, guys. Deaths of so many people. And currently, what we are using is called as a WHO reduced osmolarity ORS. WHO reduced osmolarity ORS. This is again a short note for you. When it is given, this is plan B, guys. Okay, plan B. Okay, so some dehydration, it's given. Some dehydration. Plan B. What is the composition in this? Okay, composition. Sodium chloride 2.6 grams. Potassium chloride 1.5 grams. Trisodium citrate. Trisodium citrate is 2.9 grams. Trisodium citrate. Trisodium citrate. Glucose 13.5 grams. So totally you have is 20.5 grams. 20.5. Sodium chloride, potassium chloride, trisodium citrate, glucose, and this is 20.5 grams. This comes like this, and you have to mix it with 1 liter of water, guys. 1 liter of water. And how much time you have to use it? It has to be used within 24 hours. It has to be used within 24. Okay, this is ORS. This is ORS. Okay, this is WHO, reduced osmolarity ORS. So how much ORS we are supposed to give? So this is short note, guys. Okay, short note. How much ORS? So we have to provide 75 ml per kg per 4 hours. If you know the weight, okay, after 4 hours you have to reassess the baby, guys. After 4 hours you have to reassess the baby. 75 ml per kg per 4 hours. So we have this sodium, we have 75 millimoles. Glucose, again it contains 75 millimoles. Chloride 65. Potassium 20 millimoles. Citrate it is 10. So total is 245 millimoles. 245 millimoles. It's 245 millimoles, and this has to be mixed. This, what is the advantage? The advantage is that increased shelf life. Shelf life. Shelf life means storage, longer storage. When I was studying undergraduation, it was 330, guys. 330. This one was 245 millimoles. Okay. Storage capacity will be longer. Okay, so that is the biggest advantage. It is considered as the important discoveries of the medical discovery of the last century. Okay, last century. Two more questions, then we have MCQs. Discuss the various methods of assessments of obesity. So obesity, this is again a short note for you. Okay, what are the various assessment methods are there? Okay, based on body weight you can do this. First one is BMI. First one is BMI. Weight in kg, that is Cutelet index. Weight in kg by height in meter square. Okay, height in meter square. So look here, this is how we are classifying it. Okay, so normal is 18.5 to 24.9. Okay, and obese, okay, 30 to 34.9, and this is obese class 1. 35 to 39.9 obese class 2, obese class 3 is more than equal to 40. So normal is 18.5 to 24.9, 25 to 29.9 is pre-obese, guys, pre-obese. This is Cutelet index, weight in kg by height in meter square. Ponderal index is there asked as MCQ, height in centimeter. Okay, so cubic root of body weight. Broca's index is there, height in centimeter minus 100. That's your ideal weight. Suppose if you are 180 centimeters is there, So 180 minus 100, your ideal weight should be 80 kg. Corpulence index. What is corpulence index? Actual weight by desirable weight. And it should not exceed 1.2. Actual weight by desirable weight, and it should not exceed 1.2. What about skin fold thickness? We have an instrument is there called as Herpendon's calipers. It measures skin fold thickness. What are the sides we have to measure? 4 sides. Mid biceps, mid triceps, subscapular, suprailiac. These are the 4 sides you will measure. Mid biceps, mid triceps, subscapular and suprailiac. Okay, fine. More than 40 millimeter for boys, more than 50 millimeter for girls. It's considered as obesity. This is Herpendon's calipers. So you will measure mid biceps, mid triceps and all you will measure. Okay, this is skin fold thickness. What are the other ways? Short notes only we are discussing here. Okay, waist circumference and waist hip ratio. You'll stick on to what is there in the textbook of Park. Equal to or greater than 102 centimeter in males, 88 centimeter for females, and the waist hip ratio 0.9 in men, 0.85 in female. This is considered as obesity. Okay, so 4 ways we have seen. One is based on body weight. Next we are using this skin fold thickness, waist circumference and waist hip ratio. This is the last theory question. Risk factors associated with CA cervix and its early diagnosis. Cancer cervix, okay, is the second common cancer among females in India. What are the risk factors? Can you tell me? CA cervix, right? The salient points. It's more common in lower socioeconomic status. More common in lower socioeconomic status. A multiparous women, it is common. More common in multiparous women. Early marriage, early coitus. Okay, early marriage, early coitus, it is common. Okay, and it is OCP usage. Okay, OCP usage. These are some of the risk factors. Okay, these are some of the risk factors. Okay, so lower socioeconomic status, multiparous women. Okay, early marriage, early coitus, OCP usage. Okay, how can you screen it? Screening, what you can do? One, you can do pap smear. Pap smear is costly. Okay, so doing pap smear is not costly, but you need other things are required. Okay, you need laboratory you required, cells you have to see, microscope is required. Okay, fine. What is little easier way? Easier one is VAA. VAA. What is VAA means? Visual inspection after application of 5% of acetic acid. So this is little easier way. Okay, in program point of view, we are using this much program. Okay, program we are using this VAA. Okay, you can use this visual inspection after Lugol's iodine also you can use. Okay, VALI. Okay, VALI. Visual inspection after Lugol's iodine. Okay, you can use this Lugol's iodine you can use. These are the various methods for screening this. But program point of view, VAA is more convenient. Once it is positive, you can go for other things you can see. Okay, confirmatory test you can go. What you can do for prevention? Okay, prevention, personal hygiene. Increasing hygiene is one. Personal hygiene. Second is vaccination, guys. Vaccination. Now we do have vaccines available. Okay, so ideal time is 9 to 14 years. girls. Okay, girls 9 to 40 HPV vaccine. HPV vaccine is available. So human papilloma virus, okay, 9 to 14 years girls, the ideal time, ideal time. So another risk factor is, okay, history of warts. So those history of genital warts are the genital warts. Okay, so they are having higher risk, okay, as a to develop this cervical cancer. Okay, fine. This is a short note. Okay, this is about cervical cancer. Now we'll go into MCQs, guys. Try to answer this. We didn't see these things, but you can answer it, guys. You can answer it, yes. Post exposure measles vaccine must be given within how many days of exposure? Look here. Within how many days of exposure? For a disease, okay, the incubation period is for vaccine 7 days. For vaccine it is 7 days. Okay, 7 days. So you have to give within 3 days. So if you provide vaccine within 3 days, okay, it can, okay, everyone try to answer this. Within 3 days, what it can do? The vaccine can produce antibodies that can that can prevent the disease. Next question. Antibiotic treatment of choice for treating cholera in an adult in a single dose. Okay, which one will you provide? Adult. Okay, fine. Adult. Which one will you provide? Okay, so antibiotic of choice for treating cholera, not tetracycline. Okay, so antibiotic we will give is doxycycline. Doxycycline. For chemoprophylaxis, we can use tetracycline. For chemoprophylaxis, as such, treatment is doxycycline. Doxycycline. Okay, this is for cholera. Cholera is doxycycline. Okay, fine. Scrub typhus is transmitted by, it's an entomology question, guys. Entomology question. Yes, try to answer. Flea can transmit plague, endemic typhus. Okay. Tick, suppose it's a hot tick. Okay, it can transmit KFD, tularemia, it can transmit babesiosis, it can transmit. Mosquito we have. Mite transmits what? Yes. The answer here is mite. Okay, it can also transmit, one is scrub typhus. Okay, and second is it can transmit rickettsial pox. It can transmit rickettsial pox. The scrub typhus and rickettsial pox. What is this one, guys? Today we have seen this. Height in centimeter, okay, by cubic root of body weight. Okay, height in centimeter by cubic root of body weight. Okay, fine. What is the answer, guys? What is the answer? Okay, fine. The first is Cutlet index, BMI. Okay, Broca's index, height in centimeter minus 100. This is Pondral index. Okay, this is Pondral index. Okay, corpulence index is actual weight by desirable weight. This is Pondral index. Pondral index. The new WHO ORS osmolarity is fourth one. Is the question number 4. We have seen this now. The older times we used to have 330, then 310, okay, 290 also we have seen. Okay, so what is the answer here is 245. Okay, new WHO osmolarity is 245. 245. Fine. Excellent. Excellent. 3 by 5 initiative. This was asked as a question. 3 by 5 initiative was launched in developing countries to combat. This is the goal given by a WHO. Okay, fine. A treatment for 3 million people by 2005. The old one. Okay, WHO has given this treatment for 3 million people by 2005 for ART. ART. So the answer here is HIV/AIDS. Okay, HIV/AIDS. You should know some other terminology in HIV. What is 90-99? Okay, out of the estimated cases, 90% should know their status. Among them, 90% should be on treatment. Among them, 90% should be on effective viral load control. What is this? Niche is related with what? Niche, Nikust, Niche. Come on, you can tell me, guys. 90, 90, 90. This is HIV, guys. This is HIV. Niche is related with what? Niche is related with TB. Nikust. Can you answer what is Nikust is related with what? Nikust is leprosy, guys. Nikust is leprosy. What is this niche? Niche is related with what? Niche is related with, it is, yes, pregnancy test kit. Okay, pregnancy test kit. This is niche is related with pregnancy test kit. Pregnancy test kit. Okay, guys. Fine, fine. Answering nicely. The organism multiplying and developing in the host is called as. Okay, this concept is based on biological transmission. When the agent enters inside the vector, both multiplication development happens. In which one it is cyclopropagative. Example is malaria. Cyclopropagative malaria. Cyclodevelopmental means only development happens. Only development. This is filarias. Okay, propagative means only multiplication will happen. Okay, only multiplication. This is plague. Cyclodevelopmental means only developmental. Propagative means only multiplication. Only multiplication. Answer is both multiplication and development. Then it is cyclopropagative. Malaria, it happens in mosquito for malaria. Anopheles, it happens. In all other following diseases, chronic carriers are found. Okay? I am giving what is I have seen from university papers only. So these are some vague questions, but it's answerable. Chronic carriers is seen like this: typhoid, malaria. Okay, fine. Typhoid, malaria. Okay, hepatitis B, gonorrhea, and diphtheria. Okay, these are the conditions. Okay, it is seen. Question is except typhoid, malaria, hepatitis B, gonorrhea, and diphtheria. Okay, malaria, so measles, no carriers. You are not going to see any carriers in measles. No carriers in measles. Okay, most of you answered nicely. Fine, fine. Blood smear must be made at night for which are the following conditions? Which is nocturnal? Which is nocturnal? Okay, blood smear. This is nocturnal. Yes. Filariasis is nocturnal. Filariasis is nocturnal. Nocturnal. Good, good, good. Chikungunya is transmitted not by Culex. Culex is what? JE, and what is the other one? One is JE. What is the other one? Filarias. Okay, Anopheles malaria, guys. Anopheles is malaria. Aedes can transmit. Aedes. Aedes will transmit. Dengue, yellow fever, chikungunya, Zika virus. Zika also. Answer is Aedes. Answer is Aedes. Yellow fever, okay, dengue, yellow fever, chikungunya, and Zika virus. Cluster testing is useful in detecting cases of, okay, contact tracing and cluster testing. Contact means patient sexual contact will be traced and treated. Cluster means similar people, identifying similar people, okay, similar people, okay, they are similar, okay, patient history of commercial sex workers, similar persons coming to commercial sex work, yes. So this is contact tracing and cluster testing. Both are related with STD, guys, sexually transmitted disease. STD, sexually transmitted. The most sensitive index of recent transmission of malaria. Which is the most sensitive, guys? Which is the most sensitive index of recent transmission? Recently, the transmission has happened. What is it? Okay, the most important one is this one. Infant parasite rate is the most important. Infant API, annual parasite rate, is the most important one. Spleen rate represents endemicity. Okay, APA is used to divide whether it is a high risk area or low risk. Okay, so the recent malaria transmission is infant parasite rate. It's not the slide. So recent transmission is infant parasite rate. Dash diet is for what? Dash diet is for what? This you should tell. Come on, yes. Okay, dash diet is related with what? These dietary approaches to stop hypertension. Okay, it is D means dietary approaches to stop hypertension. Next question. KFD, Kaisenor Farre disease, is transmitted by. Kaisenor Farre disease is transmitted by. Okay, KFD, yes. Yes, KFD is transmitted by heart tick, guys. Heart tick. Heart tick. This trombiculid mite only we discussed is scrub typhus. Each mite is scabies, guys. Scabies. Soft tick can transmit Q fever. Soft tick can transmit Q fever. Okay, Q fever. Fine. Yes. So we have completed. Fine. Okay. Thanks for listening. Tomorrow we will have topics on nutrition, occupational health, and one more chapter is there. Okay, fine. So we come sociology. Okay, nutrition, sociology, and occupational health. Okay, we'll see tomorrow, guys. Okay, fine. Thanks for listening. We'll see tomorrow, guys. Hope this is useful. Thank you, guys. Thank you.